the partner with this, which we also have Dr. Salman Khan and Dr. Kosha Gala, who are with us today. So MSCI is affiliated to IFMSA, which was founded back in 1951, which is also the world's oldest and the largest student-led organization, having nearly 1.3 million medical students as its part. So with that, Shrutika and Prateek will be introducing the panelists who are with us today. Shrutika.
Thank you so much, Neil, for this introduction. So, we have some really eminent personalities with us in the panel, and starting with them, we have Dr. Pankaj Sadafal. Dr. Sadafal is an epidemiologist, global health and development expert with more than 20 years of international experience, which spans Southeast Asia, Africa, and the United States. Dr. Sadafal's expertise includes data quality audits, epidemiologic analysis of complex data, public health programs, monitoring, evaluation, development of disruptive technologies, and many more. So has worked with a number of organizations associated with Global Fund, the United States agencies for international development, and other major international owners. So received his medical training and post-graduation in preventive and social medicine at Maulana Azad Medical College, and completed the Doctor of Public Health in Infectious Disease Epidemiology at the Johns Hopkins Bloomberg School of Public Health. So is currently active in the planning of social enterprise initiatives in India. So with years of work and expertise in public health sector, it's an honor to have you among us, sir. Shraddhika.
We also have Dr. Ved Prakash today with us. Sir is currently a Pro-Chancellor at Datta Meghe Institute of Medical Sciences, Nagpur. He's also serving as the National Head of Academic Program of Indian Program under Bioethics Education and Research Unit of the UNESCO Chair in Bioethics, Haifa. He's also a member of the International Committee for Bioethics for Asia Pacific region. Sir is also an advisor in the Human Ethics Committees Association, Bangalore, and a dean at the Academic and Accreditation Board, National Indian Medical Association, New Delhi. Sir is also working closely with many other organizations, nationally and internationally, IMA, SARC Medical Association, Education Promotion Society of India, EPSI, New Delhi, to name a few. Dr. Ved Prakash is also a member of the advisory board and board of management of many esteemed institutes such as Manipal Academy of Higher Education, Sri Ramchandra Institute of Medical Sciences, Chennai, Sri Balaji Vidyapeeth in Pondicherry, D.Y. Patil University, Kolhapur, to name a few. Sir has been constantly working towards bringing a change to medical education through his continuous efforts. We are honored to have you on our panel today, sir. Welcome.
Moving on to our next panelist, Dr. Salman Khan. Dr. Salman Khan is currently working as intern at Grant Medical College and JJ Hospital, Mumbai. Salman Khan worked as National Officer on Public Health for the year 2020-21 and also as Program Coordinator for Healthy Lifestyle and NCDs at IFMSA in the same year. He also served as the Vice President for External Affairs at MSAI and also held the position of Regional Assistant Asia Pacific for SCOF IFMSA in the same year of 21-22. He's currently serving as the SCOF Director at IFMSA for the term 2022-23. Salman has also represented India at various international and global conferences and continues to work towards the public health arena. It's so honored to have you here with us.
Moving on to our final panelist, Dr. Kosha Gala is a post-intern from Maharashtra Institute of Medical Education and Research, Pune. She also served as a National Officer on Medical Education at MSCI India for the term 2020-2021. She has also served as the Program Coordinator for Teaching Medical Skills at IFMSA in the last term, that is 2021-22, and was also a member of the Supervisory Council at MSCI in the same term. She is currently serving as a liaison officer on medical education issues 2022-2023 at IFMSA. We are very glad to have all our panelists today on the board. Now I'll hand over to Pratik to introduce the project.
Thank you so much, Shratika. So talking about Project Redefine, it's something which is it's very close to our heart and among all of us who are sitting here. Why we were motivated to work about this project, it just stands for, it just goes down to the fact that public health is something that is important to all of us at all part of the time. And we also find out that talking about community public health, preventive and social medicine and community health, it covers the epidemiology of diseases, national health programs, mental health, biostatistics, and international health. So there was a study that also showed that around 89% of the students agreed that learning PSM during their UG is very essential, and about 83.7% students felt that there should be addition to of field visits or practical assignments to encourage interest in the subject. And we also saw that only 12% of the students showed interest in community medicine as a PG subject. So with all such issues, and to address such issues, we at the Standing Committee on Medical Education and the Standing Committee on Public Health developed this SWG and a survey to understand the perception of public health in medical education amongst among medical students and other stakeholders.
The survey was created as part of a small working group or an SWG that was launched on 1st of August 2022, which had 18 active members, including local officers from both public health and medical education, general members, and graduated students from medical colleges of India. The SWG primarily focused on creating a baseline assessment form for gathering information on the perception of public health education amongst medical students and faculty engaged in the public health sector, along with their expectations. It also focuses on identifying key stakeholders in the public health arena and culminating it into a final report, which will be used as an advocacy tool to achieve an integrated public health curricula in medical education. Taking the next step in this project, we are having a panel discussion today as part of our project. Now I'll hand over to Pankuri and Shikhar to continue over with this panel discussion.
Thank you so much, Ritika and Pratik, for giving this wonderful introduction to the project. We would really love to start the panel discussion now by directing our first question towards the esteemed panelists. The first question is that what, in your opinion, is the ideal medical education setup with respect to public health, and how would you compare this ideal setup to the current public health model which is prevalent nationally? And if you want to compare it, you can also compare it to the international setup. I would like to direct the question to, first of all, Dr. Pankaj Sadafal, sir, if he is there. Yes, sir. Pankaj, would you like to add something?
No, I think we can start with Dr. Sadafal.
Okay, yeah. There might be a little bit of an internet lag here. I hope you're able to hear me properly.
Yes, sir, we can.
Okay. Okay. So I think, what I would say is I'll try to be very brief here because I know that there are a number of other panelists. We would also like their, responses. In my opinion, the ideal undergraduate medical public health education, I think, would involve, interaction with communities and neighborhoods in a much larger manner, I would say, than we have in the current setup. So I think, on the other hand, on the one hand, we have, very good study materials and didactic teaching as far as undergraduates are concerned. The relative neglect of public health, which was there, I would say, a couple of decades ago or previous to that, from the curriculum standpoint, not necessarily from the content point, but from the relative interest of the students. Because there was an emphasis on clinical teaching and training, and public health was not valued as much. So that has changed now. I would say in the past 2 decades or so, there's been really a sea of a change. The thing that I feel is lacking, or is needs to be strengthened, is, as I said, linkages with the communities and the existing situation in the country and internationally. I mean, just to give an example, I think we are struggling right now with the air pollution issue in Delhi, for example, and a lot of North India. And what I would say here is that the question is not just studying the issue, because we know that there's a problem, but looking at it from the point of view of trying to involve students in, interventional studies, for example, something that can achieve quick results and demonstrate the power of public health, through research and what we call action research. So, I would say there's a need to focus on looking at interventions in collaboration with communities, in collaboration with the various public health departments, whether it is the government sector or the private sector, and interlinking them, and creating a web, so to say, in the training program. So this is what I would say to start off with.
Thank you so much, sir. We do support the opinion that we need to have more collaborations and linkages, and also there is a need to have more interventions and also a more focus on research into public health so that we can promote this particular department. We would like to move on to Dr. Ved Prakash, sir, to hear his opinion on the ideal medical education setup and how would he think it works with the present scenario.
Well, my observations on this, in the context of competency-based medical education having been launched for the various Indian medical schools from the year 2019, and I had the privilege of being the chairman of the academic council of that Medical Council of India, which basically drafted this entire curriculum. The first thing which I'm wanting to put across is, whenever we are contemplating creation of an ideal educational system, there are inevitable parts which have to be looked into. Because the educational system itself will have 4 important aspects. The first part of it is the curricular aspect. I can put it across with absolute degree of humility that the curriculum which now has been structured out in the competency-based undergraduate medical education mode, including with diligent emphasis on public health and getting worked it up in the form of competency, where the competencies in the domain of public health have been defined, where the modes and manners in which they are required to be dispensed with have been structured, where the modes of assessment have been clearly spelled out, both in terms of 360 degrees assessment, which includes formative and summative assessment as a whole, including the outcomes which are required to be assessed have been crystallized. Therefore, I can put it across that as far as the structural design is concerned, I think it is absolutely in conformity with not only the international standard, but it is also in conformity with the speaking guidelines which have been put across by World Federation of Medical Education. But only creating a structure is not enough. Ultimately, the requirement will be how exactly it is going to be operationalized, actualized, executed. And on that count, the faculty development program, which has been worked up for the purposes of orientation of teachers in the country, through a structured faculty development program and through the aegis of that training imparted to them through regional and nodal centers which have been worked out over a period of time, have frankly paid dividends, because this was something which I conceived in the year 2009-10 as a part of the Platinum Jubilee celebrations of Medical Council of India, which is now paving the way for that. Out of nearly 108,000 full-time faculty in the country in 612 medical schools, so far we have been able to train 68,000 and odd faculty members on this particular count. So that requirement is also met with, and therefore I can say institutionalization of the faculty development program for handling of the competency-based medical education, including public health therein, it is definitely worked up to a great level. The most important part is teaching, learning, and assessment part of it, although again, which is structured. But then putting it into a realistic fill-up, like when I say that early clinical exposure has been incorporated for the first time, where the incorporation is very loud and clear, that it is not just a classical classroom setting, it is not just a classical hospital setting, but community setting teaching and learning is paramount, which has been incorporated right in the phase 1 of the MBBS curriculum, contemplating community setting learning, including utilization of the hours which have been attributable right in the first year for the community medicine as a subject. What I'm trying to put across is, but modalities in which this have to be linked, in terms of the present scenario, we will have to refer to Lancet Commission report. The recommendations, all that we have talked about is the stabilization of the medical education with reference to the deadline which is put across for us in the year 2023. However, there is a huge scope in which the upgradation is necessary, especially with reference to its linkage with its use, utility, outcome, and operationalization, ensuring that ultimately a career pathway gets structured for the purposes of graduates and postgraduates in the domain of public health. This will mean 2 or 3 important aspects. A, there has to be an alteration in regard to the institutional design on this particular count. And therefore, arena number 1, which has been put across in Lancet Commission in regard to institutional reforms, they have to be taken note of for the purposes of their appropriate incorporation. Similarly, instructional reforms have to undergo a sea change. Meager structuring will not do. Ultimately, competency-based handling means conversion of an innate ability of a learner into absolutely a skill, and that skill to be converted into an accessible competency, which ultimately is expected not only to be done, but it has also to be demonstrated and finally ending up in delivery. Therefore, the emphasis on not just know-how, but show how and do in terms of the Miller's mode ultimately is expected to be a translatory component, which is going to be generated as in terms of teaching and learning update, and then objective assessment of the learner, ensuring A, objectivity, B, transparency, C, accountability, and D, absolutely it has to be on the basis of internationalized credit system, which ultimately is expected to be a continuous workplace assessment, which turns out to be an important factor. And third important suggestion which I'm wanting to put across is, gone are the days when we will be able to work this out as stand-alone institutions. Lancet Commission clearly says that in 21st century medical education, it has to be a consortia approach. Therefore, we will have to work abroad. Policy interventions on this count ultimately turns out to be an important need of the hour, and therefore our observations have to be catalogued into A, policy frame, B, educational frame, and C, operational and outcome frame. It is incorporation of this. We have definitely reached a level I can put across, but still there is a gap which we are required to be achieving and attaining in order to make ourselves fulfill that gap in the international context on the ground. That today we are the largest producers of trained health manpower in the world. And therefore, if we are the largest producers, are we expected to be only mechanical producers is $1 million question. We have to be ending up in quality producers of trained health manpower, including public health, not only to cater to the national needs, but in the international needs as a whole in the global context. That is exactly the scope and challenge which is before us, for which all this thinking that we are wanting to incorporate, I need to compliment you for taking up this initiative and really working this up as a part of bringing out required opinions and expressions in order to give an appropriate input for the purposes of policy and operational frames.
Sir, thank you so much for, I think you've almost covered the gist of the entire panel in your answer. And we very strongly believe in collaborations and how interlinkages are the way forward. And with that, without any further ado, we'll move on to the next panelist, Dr. Salman Khan.
Thank you so much. I just wanted to confirm if you could hear me well. All right, perfect. First of all, it's so good to be back here. This time around on the other side, which feels like full circle. Anyway, it's very difficult to continue the discussion since the previous two panelists have very well encompassed so many points with respect to the scope of discussion. But however, I can give my opinions or my viewpoints from a perspective of a fresh medical, graduate, as you can say. I didn't have the privilege to be a part of the CBME curriculum, but I did consult and reach out to a few juniors, and I did have the opportunity to read what the structure is all about. So let me begin with, saying that the scope and the needs of medicine have changed so drastically over this century and the past century, and right now preventable diseases now account for majority of the global mortality. uh, in my opinion, medical schools should be adapting to their curricula to match the community's needs or the society's needs. Uh, in public health, theory and practice is taught throughout a medical student's career. And the physicians of tomorrow, as in all of us, should be more mindful and capable of influencing our patients' health in a proactive manner. Uh, with respect to the CBME curriculum, I would say, in my opinion, it's public health based. If we read the objectives of the CBME curriculum, the first national goal is to recognize health for all, which is so related to public health, and to learn every aspect of national policies on health and devote ourselves to practical implementation of that. If this is not related to public health, then what is? Furthermore, the institutional goals talk about management of resources related to healthcare delivery, being familiar with basic factors which are essential for the implementation of national health policies, which also include our Indian public health standards. As we all know, the curriculum is divided into four main components as knowledge, skill, attitude, and communication. The subject of community medicine, which is kind of related to public health, but is uh, sort of, there is a misconception that public health and community medicine are one and the same, but they are two distinct concepts. I would say, with respect to community medicine, all the four, as in the knowledge, skill, attitude, and communication, are touched upon. And the syllabus is well integrated horizontally as well as vertically with, almost all the subjects in the medical curriculum, including 8 form, which was recently introduced in the CBME curriculum. Uh, I would, in my opinion, say that there are some things that we can still maybe improve upon, uh, which is having a research-based environment for students who are learning public health in the medical school, as well as tailoring the curriculum according to the needs of local communities. And also the fact that the current pandemic has captured the diversity of public health by recognizing the involvement of not only healthcare professionals and epidemiologists, but also, let's say, engineers, social scientists, administrators, biologists, you name a profession, and all of them were involved in curbing the effects of the pandemic and, sort of working towards the public health of our nation and the world at large. So we could have more involvement, or rather, let's say, more understanding of interprofessional collaborations in public health. I think this is an aspect that could be worked upon in our medical curriculum. And with this, I think I can pass on the floor back to Pankuri. Thank you so much.
Thank you so much, Salman. We also think that the way CBME has overtaken and stated out certain competencies, that is quite commendable, but we can always look forward to having better implementations at the institutional level. We would like to move on to Kosha Gala to have her opinions on the same.
Thank you so much, Shikhar. I hope you guys can hear me. If you cannot, just let me know in the chat. So I think almost all of what I had noted down has been discussed to a certain extent. I resonate with each of the panelists that have spoken before me, primarily also because I have experienced the UG curriculum in India, and now I see what my peers in other countries are experiencing with respect to public health. Say with respect to what Dr. Pankaj said about engaging stakeholders, I absolutely believe it's very important for us not just to engage stakeholders, being the bigger stakeholders like the governments, but also the stakeholders that do not have high power but have a very high interest, like our communities. The other thing that I think is very important in an ideal curricula is the motivation for the curriculum developers, every stakeholder involved in the delivery of curriculum. It should not be something that is driven by, say, an accreditation system, but rather an internal motivation of we want to give what is best for our learners and make them competent with the global practitioners' competencies. Apart from that, I also believe that investing the government resources is very, very important in research, in innovations, in health education, because at this point in time, we have a lot of resources that are existing in silos, and we need to maybe just break the silos and the barriers to know where to invest and how to use the health workforce that we have currently at its maximum capacity. And lastly, I would just like to wrap my points very briefly by mentioning that active engagement of medical students in the curriculum design and research in public health is very, very important, because at the end of the day, you need to know what are the needs of your learners. And this, along with incorporation of interprofessional education, as Salman mentioned, and highlighting the patient's needs. So making sure that the patients are also involved in deciding the kind of curriculum that is delivered is something that is very important to make our curriculum as close to ideal as we can, referring to the WFME standards or the standards set by India. Thank you so much.
Thank you, Kosha. We also think that there could be globalization of the competencies along with proper stakeholder engagement in order to have a more effective curriculum, and obviously the public health education can be improved in that aspect. Now, I would like to request Pankuri to move on to the next question.
I think all of our panelists have very beautifully summarized what is the ideal medical education setup, especially in terms of the public health education. But we also understand that the reason why we are sitting here is because that barriers to achieving the ideal exist, and they exist not just in one sphere; they exist in all spheres. Like was also highlighted by a few of you, they exist in the student community, they exist in the educators community, and they also exist at the institutional and at the public level, at the governmental level. So we'll go in the same order again. And my specific question being, what, as per your experience, are barriers to public health achieving its maximum potential in all spheres in the current medical education setup? Is so we'll start with Dr. Pankaj and move further.
Okay, yeah. In terms of barriers, I think like what has been mentioned, if we were to sort of divide it into the student, faculty, and institutional barriers, I think at the student level, I think what is important is to ensure, and this of course has to come from the student side, but there's also an element, from the faculty and the institutions in terms of ensuring a very high level of motivation for students. So I think that's a very important starting point. It almost goes back to the issue of why a student wants to become a doctor, a medical doctor, or wants to go into public health later. What exactly does he want to achieve, and what are his long-term goals? So I think it. So one of the issues is how does a student, how does a medical student look at his or her career path, in the long term? What is the role that that student sees of public health in his career, whether or not he intends to pursue it as a post graduation or as a full-time career in the future, because there is so much of an interdisciplinary aspect at this point in public health. um, I think more and more we will all, I think, notice that uh, epidemiologists or public health specialists are being called upon to have skills in, like very high level quantitative skills, or have analytical skills, or have to deal with the software and technology, and especially I think trying to develop appropriate technology. So I think so motivation is, I think, is a key factor, and from the student perspective, I would say. Um, from the faculty perspective, I think opportunities to be able to gel with the international community, the scientific community, other international faculty, or being able to attend conferences or having, even if not attending physically, now that there's so much of the online, collaboration or workshops or conferences, to be able to set aside some time for those kind of activities, I think is very important. And sometimes what happens is that the faculty member is bogged down in a lot of teaching, didactic teaching, and not having sufficient time for renewing their perspectives, or having fresh approaches, bringing in fresh approaches into the institution. So I think that's what I would point out from the faculty perspective. And then I think, of course, related to that also is having the appropriate setup in terms of teaching aids, technologies available in the institution. Sometimes things just as simple as having a good internet connection, things like that. So those can be very critical, I think. And in this also in this aspect, I think being able to, like I said, connect with researchers, faculty globally, having multi-centric studies, for example, having research that involves international teams. So that and then bringing that into the teaching. So like I said, making it more current and relevant. So I think that is important from the faculty perspective. From the institution, I think I would go back to the issue of having an interdisciplinary approach, having collaboration between the clinical and the public health faculties, as well as the basic sciences. So even with the research, trying to develop a research, that and then bringing it into the curriculum and across the board in terms of disciplines, and having collaboration between the different departments. So I think that can only be achieved when the heads of the institutions realize its value and put in both effort and funds into collaboration across departments. And when I say collaboration across departments, I think I'm also we have to consider collaborating also outside the institution with the communities and the other public and private institutions in the area. So this is what I would I think if I were to summarize.
Thank you so much, sir, for your words. We understand that what you emphasize the most is about more exposure and more collaborations at across all sectors. And I think it is more than ideal to have Dr. Ved Prakash Mishra speak after you, considering that sir has the right stakeholder approach to this. So, sir, what would be your answer?
Yeah, I think the barriers are there at all levels. And therefore, the key operators in the game have been rightly picked up for the purposes of decipherance of the barriers. See, having been a part of this entire system for almost now 4 decades, the barriers which existed in my time continue to exist even today. And therefore, there is something which is called as a statism, which has come in the entire dynamics of medical education, especially from the point of view of a learner. Number one, there is a barrier pertaining to the clarity pursued by the learner. Number two, purpose pursued by the learner. And 3, priority pursued by the learner. These are the 3 important aspects which are the edifice of his purpose of learning. And that is one of the important aspects we cannot lose sight of. We have never been incorporating the learners in the domain of the medical education on the basis of an aptitude analysis. And therefore, that by itself turns out to be one of the important missing links in terms of whether education is getting a right class of the learner, or whether the learner has chosen a deserving learning which is expected to be absolutely made for each other. This is a generic barrier which I am putting across. Number two, as I said, you work out, the learner is entering the portals of medical education, which a priority which he is predetermined about. Therefore, that predeterminism is absolutely lost in the context of self-determinism during the course and the curriculum. That is the second barrier. The third important aspect is, on all these two, his future plans and his future makings, they are going to be a key decisive factor. And perhaps it is in this context that, for the best known reasons, whether we like or do not like it, the fact of the story, even your survey, why is it that only 12% of the people are wanting to be opting for community medicine as the postgraduate inclination of theirs, which goes to indicate that career making, future making, which is expected to have a very important aspect on the prioritization and choice of the learner, the mismatch which is there is palpable. Now, it is in this dilemma where the learner is wanting to be going in for the entire process of learning. And therefore, what I'm trying to put across is, these dilemmas which are intrinsic to the learner, they by themselves are individualistic barriers. Number two, there are collective barriers, the ambience, the environment, the working patterns, and the working leanings. Those are the second important barriers which are there at the point of view of the learner. The third important barrier is the cultural diversity to which a learner is plagued to. The All India examinations have definitely added to, and rightly so, the cultural diversity which is there in the learner, and therefore that by itself turns out to be a barrier. Acclimatization to the working environment is another important barrier which turns out to be a cardinal factor. Therefore, when it comes to individual, and most important aspect is lack of counseling, lack of guidance, lack of that needed emotional support, mentorship program which was expected to be there for tiding over all these situations. How efficacious those mentorship programs are, perhaps, is a matter of common experience to all of us. Therefore, there are definitive barriers at the level of individuals, there are barriers at the level of collective perception, there are barriers at the level of cultural diversity, there are barriers at the level of acclimatization, and hardly there exist any redressing mechanisms handily, easily, and effectively available to be rising to the occasion to come as a succor and a recurrence to that. And perhaps peer pressure is another important aspect which ultimately is going to take a sway on him. When it comes to faculty barriers, I have visualized faculty barriers. I'm putting gross. There could be many micro assessments. One, there is a barrier pertaining to the capacity building of the faculty. That is the most significant aspect which I always find. And therefore, I said faculty development program, and not only faculty development program, evidence-based medical education turns out to be an important aspect for the purposes of incorporation, and that is an important link or barrier which is there at the level of the faculty. Just as capacity building is one limitation, second is faculty at the level in terms of the available numbers. 612 medical colleges, if you take the prescribed numbers, where are those faculty members who are available to us for the purposes of even fulfilling the minimum requirement? Therefore, number is also a big crisis. As I said, numbers could have been worked out in terms of consortia approach, but standalone institution is the rule of the day in terms of the policy frame. And that turns out to be a second important limitation, where the inadequacy of the manpower, leave aside existing manpower which is impoverished in the context of capacity building, is adding to the torment, but non-availability of the number itself. And imagine when the option by the students for the postgraduate program itself is going to be low, imagine where exactly the faculty is going to come from, which is appropriately equipped with the required qualifications, and therefore the deficiency of the manpower plagued by existing manpower, paucity of the capacity building turns out to be an important aspect. third important limitation or a barrier which I'm in a position to put across is, in the entire curriculum, the requirement of field research, community research, project research, which is required to be there for the purposes of incorporation of research skills, that update itself is inadequate or non-available, or turns out to be a matter of a victim of apathy. And these are absolutely barriers at the level of faculty. And therefore, you will be finding the desired work pattern, which is ideally required, is absolutely missing on a good number of counts. Where things are good, they are excellent, but where the things are bad, they are very bad. And therefore, the level playing placement, which is required to be there among the institutions, is missing. And last is prioritization. In the entire prioritization game, the required mechanisms which are which are mandated for the purposes of required support are also lost in the game of prioritization. And there are n number of examples which I can cite on that. When it comes to institutional mechanism, ultimately institutional mechanisms means a work culture which is the responsibility of the institutional profiling, which unfortunately is also equally a missing link in the entire situation. No accreditation mechanisms in this country is taking another important toll as far as the institutional profiling is concerned. Imagine, the NMC Act contemplated creation of an accreditation board. From 2019, 3 years are over. We do not have even the regulation against which the medical institutions in this country are to be rated, ranked, and accredited. We are still required to be looking towards NAC, which was never created for medical education, and there is no modality whereby the medical education could be assessed. And institutional profiling, which does not have a culture of collaborations, linkages, collaborations not only with the community, but collaborations equally with surrounding institutions, clustering of the institutions, matchable institutions, and which could help in building up exchange of the good and healthy practices for the update. Even on that count, it is missing. And finally, the administrative propriety and the administrative propensity, which is needed on this particular count, also is missing from the administrative leadership of the institutions, and much less in a privatized setup where perhaps even administration turns out to be titular heads. The malady is far more heavy and far more complicated in the context of public sector-based medical education and private sector-based medical education. Therefore, what I'm trying to put across, friends, barriers are definitely there at all levels. But to think that the barriers are unsurmountable is equally foolish. All these barriers are surmountable, and there are efforts which are going on in a diligent way for the purposes of surmounting these barriers. That is the ray of hope for all of us. Thank you.
Thank you so much, sir, for such a comprehensive answer. And I would just like to summarize that, what you mentioned was that there are intrinsic personal barriers at the learner level, and then there are barriers which translate to faculty level, because then students do not pursue the speciality further, and then thus all of this translates at the institutional level. So it becomes a big vicious cycle. And with that, I think there was a lot of information on intrinsic barriers that sir mentioned that come at the student level, wherein there is no learner attitude analysis. There are a lot of predetermined notions, and self-determination is also lacking somewhere. So as a graduate, what do you think, Salman, are barriers at these three levels?
Thank you so much for giving me the floor. First of all, I'll thank Pankaj sir and Dr. Ved Prakash sir for beautifully putting up the points with respect to barriers related to collaborations within the institution and also beyond medicine, individual barriers, as well as collective barriers. And, it did give me somewhat motivation to, further pursue public health and further solidify my motivation, and hopefully address these barriers in the near future in whatever capacity I can. So starting off, I will address a very unpopular opinion, which is the elephant in the room for medical students. Public health, or rather PSM in our context, has been traditionally given as stepsisterly treatment by the students themselves. Let me quote a definition. Public health is the art and science of preventing diseases, prolonging life, and promoting health throughout the organized efforts of society. We read the definition, we memorize it, we stop there. National health programs are mugged up and memorized rather than understood. For instance, quoting another example, Ayushman Bharat, the rationale for that program is to provide comprehensive healthcare in the form of free essentials, drugs, and diagnostic services on all levels. We can relate this to the concept of universal health coverage. And the insurance scheme under Pradhan Mantri Jan Arogya Yojana can also be related to this. Instead of connecting the dots and understanding the rationale behind these national health programs and our duties as healthcare professionals or even public health, people working in the public health sector, instead of understanding the importance and instead of incorporating them in our practice, we just end up learning and it's manifested as short notes for 4 marks each. It's going to be a short note for Alma-Ata Declaration, short note for Pillars of Primary Healthcare, UHC and Ayushman Bharat scheme. Nothing beyond that. This is an individual barrier which is faced by, in my opinion, every second medical student in our system, which needs to change, which frankly needs to change. This is the elephant in the room that is hardly being addressed by the medical students themselves. Furthermore, IFMSC had conducted a survey around 5 years back, the time when I started off my journey in medical school. The survey was conducted amongst medical students in 139 countries, and majority of them indicated that they do not seem to enjoy public health learning. So the barriers are not only national, but also regional and international. There are differences not only in various countries and regions of the world, but also medical schools inside the country, medical schools, in different states of our country. So, although development of a one standard curriculum gives us, some sort of framework or guidance, but it's not like the best or it's not desirable. Every locality needs to have some sort of an objective strategy or plan on public health teaching based on the local setting and the actual requirements of a community on local level. Apart from that, I would say our teaching traditionally has not incorporated different learning styles and preferences to begin with. So this is also another barrier that we have been actively addressing through the CBME curriculum, but obviously Rome was not built in a day. So this change that has recently been adopted will show some long-term efforts, or sorry, rather long-term effects eventually. So yeah, I think that's all from my end for now. Thank you.
I think I would just like to thank Salman for highlighting a very major factor that I think is in all medical students' minds that are sitting in this Zoom meeting today. And I think with that, we would like to proceed to Kosha and hear her views as well on what she thinks are the barriers in the 3 states.
Thank you so much, Pankuri, again. So yeah, again, I'm the last one to speak, but at the same time, I really relate to what all has been said already, especially Dr. Ved Prakash. The way you describe the barriers is something that is not just something I see as a third person, but something that I have experienced in a personal point of view when I went through medical school. So it took me back to my third year in medical school where I was going through the PSM postings and understanding, okay, why do I need to know about, say, millets, or how is something grown in a farm? And that is the one thing that really resonated with me in terms of how the system currently is. We are still trying to change and we're still trying to transition to CBME, and what is the scope of CBME if it is implemented in the most effective way in our curriculum. With regards to my response to the answer, I will again go in the same order. So if I start from students, I feel the first thing, as already mentioned by my panelists here, is the lack of motivation for many to participate in any kind of initiative, be it advocacy initiatives or having any leadership roles in extracurriculars or in the curriculum. It is something that is a very big barrier in terms of advocating for change, and being a part of the process. For example, through 4 years of my medical school and participating in different NGOs, including MSCI and now IFMSA, I now am the student representative for IFMSA and the only student representative in the WFME Executive Council. And IFMSA has also participated in the development of the basic medical education standards that were updated in 2020. So all of these are small steps that we can take as students, with continuous advocacy and sustained efforts, to make sure that we have a voice instead of say cribbing about the fact that we are not involved, we are not engaged. We try to actually make change. Another thing with students is many a times they go to communities which have major barriers like languages, or they are not given adequate training in terms of EDI and knowing the communities, which can affect their soft skills and the way that they act in communities. And the last, as Salman already mentioned, is the perspectives that we have towards public health or community medicine in our country, which is something that has to change because we do not understand the scope of public health and community medicine, especially in 2022. It is something that is growing and continues to grow with newer branches, with relevance increasing each day, and something that has a lot of opportunities for us as future practitioners too. Secondly, going to the faculty, I believe that there is a lot of room for us to develop and use newer teaching styles. For example, I was at the AME conference this year and I got to see so many presentations of different kinds of teaching styles that educators are using around the world. And these are not teaching styles that are dependent very heavily on, say, infrastructure or finances. It is something that is very ingenious that they have developed with the resources available. And that is something that we can continuously develop on and also capacitate our educators on. Coming to the second point of increasing the capacity building for our educators and teaching them how to deliver the CBME curriculum. Yes, we have an amazing curriculum on paper, and we already have started different projects to capacitate every stakeholder involved. But we need to make sure that it is a continuous process and something that is not just a one-time thing for us to. And another thing for faculty, I think, as already mentioned, is how understaffed we are. Because if a class of, say, 100 students has 2 teachers for anatomy, I don't think it's fair. You need to make sure that if your community, say, is of the ratio that we have to our community is humongous. We already are very less doctors in the cycle, but having even fewer educators makes it very unsustainable. Coming to the health workforce 2030 agenda, which is something that is a reality check for many of us of how severely understaffed can the health workforce in the world be. And lastly, for the faculty, I still believe that there is a lot of room to create standards within our country too. Like WFME has created standards, which is a perspective-based approach, giving us a lot of room to measure our own effects of what the faculty can do and what can be done with the existing resources by our faculty. And lastly, going to the institutional level, I again would reiterate the very similar things, just investment into the health workforce, research, promoting research in public health, creating newer opportunities for students to engage, creating, say, remote internships, having more elective programs. You can even establish a skills lab, standardization for assessment methods, and collaboration with other institutions. These are some things that can definitely be looked into in terms of institutional barriers that exist and how can we possibly go beyond the barriers and try to mitigate the same. And there is already an increased priority in terms of global standards, but we need to make sure that we are translating them into the local context in medical education. And for this, I think a comprehensive framework on how should, say, the WFME global standards be translated and developed into a local framework for our communities and our institutions is something that can definitely be developed and sent to institutions to have their own perspectives on the same and see what can they do in terms of their innovations. And lastly, I think I would just say something that I have felt personally as a medical student. Sometimes I do believe that the topics in public health are vast. It's a humongous thing to cover in, say, 2 semesters or 3 semesters. but we need to make sure that we have a curriculum and segments of the curriculum that are still relevant to us. So making sure that the curriculum is updated, the content is updated, instead of focusing more on the theoretical or the historical aspect of some issues in public health, like say some government acts that have been proposed in the past. Let's think of ways to develop the ones that are existing right now and see what can be done for the future policies that we create in the government. So that is pretty much what I had for your answer. I hope, Pankuri, that answers the question. Thank you.
Absolutely. I think, Kosha, you've very beautifully highlighted the all the major barriers, and you've also given out some very, very, very innovative solutions. And I think with that, we can move to the last part of the panel, and I think I'll hand over to Shikhar, and we can begin with Kosha, considering she's already started the baton for solutions um, on this panel.
Thank you so much, Pankuri. So we move towards the end of this amazing panel discussion that we have been having. As the amazing public health and medical education experts that we have over here, so I would like to ask, what are the solutions to the huge number of barriers which have been stated out by all the esteemed members of the panel? And also drawing to this entire panel discussion to a close, what would be your closing remarks to call in action for current students and also future healthcare professionals? We would like to start with Kosha, as has been already stated. Thank you so much.
Thank you so much, Shikhar. Yeah, I think I jumped the gun on the last question by also starting on the solutions. I apologize for that. But just continuing on to what I said, I can start with, say, the institutional level. As I already mentioned, investment in infrastructure, training, research, innovation at the local level is something very important. Second is our ability to partner up with local stakeholders. Say, for example, in India, we have village heads or sarpanch that are the leaders in, say, the smaller communities in the rural setting. We can potentially look for ways to partner up with them and make sure that we know the needs of the region. And at the same time, we are able to communicate with the region in the most effective way. The other thing that we can focus on is creating a socially accountable curriculum. So highlighting how social accountability in medical schools is very important. Say, for example, having an elective for students to understand the scope of social accountability is something that we can think of working on. And the next is, say, for example, we go to the faculty. Teaching methodologies obviously can be innovated. We can think of small working group as a common way to teach subjects in public health, case-based learning, problem-based learning. We can also use gamification. The list is, there is a lot of room for innovation, and the list already existing of various ways we can facilitate discussions and create learning strategies for students is endless. The next thing that the faculty can do is they develop their own competencies in CBME and know what is the scope of the curriculum, how to develop objectives, learning outcomes for the sessions that they create, and in general, how to deliver CBME and to create global practitioners. The next thing is the importance of interprofessional education. Like I already mentioned, the health workforce that we have is already very limited to us, and using the existing health workforce to its maximum potential, practicing IPE is something that can definitely give a very cohesive and rounded approach to many topics in public health for the students. Just for them to experience what it is like to go through a multidisciplinary curricula, and at the same time, what they can also learn is the different soft skills that you can use in a hospital setting or a community setting when you're engaging with other disciplines of medicine. And this can also contribute to their hidden curricula, because the hidden curricula that we experience many a times is not what is intended. And by, say, promoting IPE or patient involvement in medical education, we can make sure that the hidden curriculum that the students experience is in its essence the most positive that they do in terms of engaging with other disciplines. Lastly, for students, I believe, again, actively engaging and advocating in community projects, taking up research initiatives in public health, understanding the needs of the community, engaging with their communities, say, for example, adopting villages. I know that has been done in many universities already, is something that they can do. Lastly, I would just like to say that the WFME principle-based standards, they meet the needs of different regulatory agencies and medical schools around the world. but we just need to make sure that we contextualize the same to the needs of the community of India. That's all I have for you, Shikhar. Thank you so much.
Thank you so much, Kosha, for telling us such amazing solutions, and also we reinforcing the importance of advocacy in medical education and social accountability. We would like to listen to the opinions of Dr. Salman Khan on the same.
All right, thank you so much. To summarize, the departments of, let's say, community medicine or public health at large should be the primary domain of medical professionals. So use of epidemiology, biostatistics as tools to function the fundamental levels of academics, research, service delivery through medical colleges should be the primary domain, while we should also integrate veterinary, human, and environmental medicine to sort of develop the emerging concept of One Health. With that, I mean, we should catch up with what has been happening recently globally. I'll start off with medical students first. We can take simple steps, which can be long-term as well as short-term. We can engage in public health research through, let's say, summer electives or the public health exchanges that MSAI is a part of, or addressing a public health issue in your community through, let's say, any local NGOs, or even MSAI for that matter. You can participate in MSAI local activities as well as national activities for public health, and also conduct your own surveys and local data connections that will sort of help you experience research and public health firsthand. With respect to let's say involving other stakeholders or improving or rather upscaling the public health training in medical schools, I would say that we should collaborate with public health specialists and academics for higher quality teaching for public health in medical schools, apart from our faculty for community medicine, and also enable networking between different public health professionals and medical students. Apart from that, there should be continuous research and development for modules in the undergraduate curriculum, which aim towards increasing the knowledge, interest, and motivations of students regarding public health, including everyone, not just those who are primarily focused or interested to pursue public health in future. We could sort of have local public health case studies as teaching examples, or encourage students to engage with local community health projects and institutions, encourage and support students to attend public health conferences as well, and educate future doctors on healthcare disparities. Healthcare disparities are a problem that is not very well touched upon by students themselves, and also at times in the institution too. So that's all I have to say from my end.
Thank you so much, Salman, for sharing your valuable inputs with us. Now I would like to request Dr. Ved Prakash sir to enlighten us with his opinions.
Expressing my total concurrence with what Dr. Kosha and Dr. Salman put across. I shall be limiting myself only to long-term policy interventions because I feel I can deal them better. Well, my first gross observation on this is, and I am fortified by the prediction which was made by Flexner when he put across his report, that these inclusions shall be governing the global medical education for 100 years. And this was the postulation which he put across in the year 1910. And that was the reason why Lancet Commission report is 2010. So 100 years of global medical education has been governed by Flexner's committee report, and by and large, if you divide that into formative and reformative stage, the formative and reformative stage of the entire spectrum is over. Now we are on the transformative stage, which is there in terms of Lancet Commission. Therefore, my first contention is all that we are discussing in terms of prescriptions, in terms of indications, in terms of summative discussions have been focused and categorically brought out in the Lancet Commission report, which I believe is globally applicable, including India, wherein, as I said, instructional initiatives, institutional initiatives, and educational outcome initiatives have been catalogued. And the shifts that are required on each of these three heads are catalogued. Therefore, my first observation is, be it medical education as a whole, including public health therein, Bible to me appears to be Lancet Commission report for 21st century to be adopted per se for its operationalization, contextualizing it into the Indian scenario. That is my contention number one, which should be picked up by Niti Aayog in the right earnest, and the standing group already is seized with this particular idea. Number one. Number two, having said so, the second important aspect is, ever since 1956, medical education has been deprived of any entitlement of developmental grants in the Indian context, as it is applicable to higher education in terms of the University Grants Commission Act 1956 under Section 12B, whereby every 5-year plan, allocation of the developmental corpus is made available to be disbursed for the cause of higher education through University Grants Commission. Such a developmental grant has never been available to medical education in this country, and therefore the resource scarcity which plagues. See, it is not only just the private colleges that we are talking about. The resource scarcity that plagues the entire spectrum of medical education in this country, the mother repository lies in the fact that there is no developmental grant provision, because medical education is outside the purview of University Grants Commission, and University Grants Commission was meant for the purposes of disbursement of planned grants in the name of developmental grant to the institutions for the purposes of developmental profile. Although we have been able to get a commission, but such a financial disbursement is not available to medical education. Therefore, as 12B is applicable to higher education in this country, medical education either should be brought under the purview of 12B, or in terms of now a national medical commission, it should be vested with the authority as University Grants Commission is vested with for the purposes of disbursement of grants. That is the second important requirement. Third, ultimately, there cannot be regulatory recognitions will never be in a position to do quality centricity, which is mandated in the context of education. When Dr. Kosha was wanting to put across incorporation of WFME guidelines, they will not only mandate contextualization, they will require policy decision, incorporation of electives, incorporation of free electives. Luckily, national education policy documents talks about it, but National Medical Commission is outside the purview of the apical regulatory frame, which is going to be there even under the NEP. Therefore, the entire perspective of regulatory frame that is going to be recognizing the medical schools and approving the medical schools on the basis of minimum standard requirements will never be in a position to assure and guarantee quality centricity, including in the domain of public health education. And therefore, the requirement is that we should, just as we are talking of the developmental grants, there should be also a accrediting body, ranking body, rating body, which will be in a position to go in for accreditation of medical schools in this country. And third, ultimately, when you're talking of collaborations, it will entail a policy decision. And that policy decision will have to be taken not only in the context of national consortia, international consortia required to be formulated. 2022, in May 2022, A+ accredited universities in the domain of higher education are now entitled to make all foreign collaboration, which is not applicable to medical education in this country even today. Therefore, 4 important policy frames which are mandated as a long-term solution, not long-term, immediate solution for which a long-term policy frame is necessary is in the terms of A, adoption of Lancet Commission for the purposes of contextualization of the Indian system of medical education within the purview of the same, and a long-term plan for that is necessary. Number 2, incorporation of developmental grants applicable to medical education for the developmental profile on par with higher education in this country. Number 3, institutionalization. Academic staff colleges are there for higher education, but there is nothing like academic staff college phenomena for medical education in this country, and therefore on that count also it is an orphan. Therefore, academic staff college frame being made applicable to medical education that will facilitate capacity building. Fourth important aspect is who prescribes pay scales for medical personnel in this country. Even today, medical teachers are set to be paid on the basis of UGC scales. Why is it that the pay scales applicable to medical teachers in this country cannot be put across by an authority designated for that particular purpose, keeping in view the nature and the importance of the work and the prioritization and the level which is entailed with the medical education? A separate class and cadre turns out to be of equal necessity. And for the purposes of career making, I have worked out an independent report which has been accepted by the Government of India on creation of Indian Medical Service for the purposes of administration of both education as well as the healthcare services in this country, which by itself creates a path for educational administrators as well as public health administrators in the given situation. And therefore, I mean, they may be sounding, imaginary, but I believe the problems which are entailed in it, they cannot be sorted out by small time interventions. Even if they are, they will be capable of taking redressal at a very minuscule level. There is a larger chiseling necessary, which is mandated in terms of the policy frame. Therefore, I sought your concurrence that I would like to dwell on 4 or 5 important aspects which I have been able to conceive in this particular area, which mandate policy intervention for the purposes of A, contextualization of the Indian system of medical education vis-a-vis global parity. Thank you.
Thank you so much, sir, for focusing upon the long-term policy interventions. You have raised some various poignant questions, which we hope to incorporate in our report. Thank you so much. Now, we'd like to request Dr. Pankaj Sadafal, sir, to share his views on the same. And also, we request you, sir, to tell us what are his views on the topic, on addressing the issues of policies being something else on paper and something totally different when it comes to the implementation. Over to you, sir.
Thank you, Dr. Shikhar. I'd like to thank everyone. I think a lot of ground has been covered in terms of, suggesting solutions. So in the interest of time, I think, like I said, across the spectrum, there are a lot of solutions that have emerged. And I thank Dr. Koshagala, Dr. Salman Khan, and Dr. Mishra, for all the suggestions. Especially from the policy perspective, Dr. Mishra has covered them really comprehensively. What I think I'm just going to focus on maybe 1 or 2 points, one thing which I think has emerged and which I feel should be really followed up strongly is, for example, forums such as MSAI or IFMSA, to use it as a sort of a stepping stone to develop collaborations, cross-institutional collaborations, to find solutions for public health education. I think this could be a very good starting point, which could be used, which you could use to fill the gaps and to find solutions and work on those which have already been suggested. So I think that, and similarly, I think although we find today that, for example, social media has its own sort of drawbacks and problems, but I think the correct use of social media could actually also help in strengthening and finding solutions to the problem, especially from the point of view of sharing experiences, developing case studies, or even on specific areas of the curriculum where students feel that there are gaps. So I think that could be another sort of platform which could be used, which could be exploited to benefit the students. Now, in terms of what I think Shikha was mentioning about the disparity between what is in the policies or frameworks and that is on the ground. I think for this, I think it's essential to have a feedback loop from the medical student community as well as the the larger communities, as I mentioned, and which is why I was emphasizing all along about linkages between communities and the institutions. You know, when I say institutions, it includes faculty and students. So having a strong, linkage between neighboring communities that neighbor an institution, and the personnel, the students, faculty, and even the other administrative personnel in the institution. Also, I think when we talk about community, also the larger administrative functionaries in the community, like for example, the district collector or the CEO and other functionaries, to have them also included in the discussions about public health, education initiatives and research. I think could be of benefit, and it should be explored to the maximum extent possible. So I think I'm going to stop here. That was really what I wanted to highlight, and I'm happy to add further as needed.
Thank you so much, sir, for your inputs and for specifically answering the question that was also asked in the chat box. With that, we also have had Salman and Kosha answer to other questions in the chat box itself. Uh, I would just like to summarize that you've all mentioned interventions and calls to action in key domains of curriculum design, student involvement, and changes at the policy level. And I think we would love to incorporate all of these in our report when we prepare for our project and send it out to you and other relevant stakeholders so that some cognizance is taken about the topic that we are advocating for. With that, I would like to hand over to Neil to close the discussion for today. And
Thank you so much, Pankari, and thank all the panelists who are here with us today for spending your valuable time with us over this weekend on discussing various issues on, how the existing, public health education model is, what are the barriers and the solutions for the same, and how we as a future healthcare provider can intervene at various levels. So it's inspired all of us. And with us, we also have various medical education and public health enthusiasts who have joined us as participants with us. So I would like to thank the participants as well for, spending your valuable time over the weekend. And finally, with that, all the inputs and the suggestions that have been, raised and put up by the panelists have been documented for curating the report, which can always be used for advocating. With that, we'll also like to click a picture with all the participants and the panelists together. So I request each and everyone in the meeting to turn on your cameras. So I'll wait for some time.
we'll wait another